Employer-sponsored health insurance premium costs rose 203% between 1999 and 2015. Clearly, that increase outpaced inflation and workers' earnings. Deductibles increased during this time as well. Let's take a look at healthcare plans. There's some good news, however. The cost of family premiums slowed from an average of 11% annual increase to an average of 5%. The cost of family plans, employer and employee parts, ranged from below $10,000 annually to over $24,000 annually. Healthcare costs have increased for a variety of reasons. Individuals are living longer and working longer. Whether we like it or not, there's often a correlation between one's age and the need for healthcare, and newer medical technologies, as well as drugs for treating everything from headaches to cancer, are often costly. Companies employ a number of different approaches to maintain healthcare costs. These approaches include traditional plans, managed care, high-deductible healthcare programs, generic and mail-order drugs, and wellness programs. Traditional plans include those available through insurance carriers, community-based plans such as Blue Cross, Blue Shield, and employer self-insurance. Under these traditional, fee-for-service plans, an employee typically has to meet a deductible before the insurance plan pays for most medical services, and even then, the plans sometimes pay only 80% or less. Employees can choose the doctors they want and usually don't have to live in a certain geographic area to participate. These plans generally do not pay for preventative care and pay only part of the costs of diagnostic tests. Managed care plans are the oldest of the approaches to healthcare cost management and include health maintenance organizations, preferred provider organizations, and point-of-service plans. Major differences in the three types of plans include how payments are made and the way medical costs are determined. These plans provide health care to members for a set monthly fee for a comprehensive set of services. Primary care physicians serve as gatekeepers. Health maintenance organizations known as HMO, the first type of managed care programs, originated in 1973 when the Health Maintenance Organization Act became law and allowed third-party payers to participate in healthcare payments. Third-party payers are companies, insurers, and other entities that negotiate healthcare options for employees rather than the employees doing so directly. HMOs became very popular in the 1980s. They often require that an employee live within a designated service area and use doctors and facilities that are specified by the HMO. The plan pays for medical services if the health care providers are designated in the plan. Each employee identifies a primary care physician and then goes to that person, who can then refer the employee to a specialist within the HMO if needed. A second approach to managed care is the use of preferred provider organizations, or PPOs. In a PPO, an employer negotiates with healthcare providers, usually in a network, for discounts. The providers must follow strict standards about the number of diagnostic tests they order and must adhere to cost controls. The employer also gives its employees an incentive to use preferred providers. When they do, the rates they pay are lower. Thus, employers save money on their healthcare costs, employees have a greater choice of doctors than they do with an HMO, and doctors are assured a flow of patients. If employees use a doctor not in the PPO network, they pay a higher copay. A copay is a minimum amount an employee must pay for healthcare, including a doctor's visit, a prescription, or a diagnostic test. The third type of plan is a point-of-service plan. This plan can be best described as a hybrid between an HMO and a PPO. In a POS, the employee can decide which plan to use as needed. The employee might choose to use the HMO component to see a primary care physician, but receive treatment following a referral through an in-network physician in the PPO. Individuals can also receive treatment outside the network, but must pay a deductible of $500 or more. The HMO and POS options tend to have lower premiums, costs to belong to the plan, than PPOs because they require that the primary care physician decide whether an employee should be referred to a specialist. They also have lower premium increases than PPOs as a result of this requirement, although in the past couple of years that's been changing. There are, however, a number of criticisms that have been raised regarding HMOs and POSs. One concern is that physicians act as gatekeepers to the care of patients. Due to the way that physician payments are structured, the plans can give physicians an incentive to limit their patients' access to specialists and certain diagnostic procedures. In fact, as a result of consumer and government pressures, HMOs and POSs have been approving more patient referrals in recent years, even though the practice drives up costs. Another criticism of HMOs and POSs is that the plans limit how much the employee has to pay out of pocket for costs. Consequently, employees may not be as careful about taking care of their health as they would be if they had to pay more of their healthcare costs themselves. Employers have adopted a variety of alternative approaches to address the concerns about healthcare plans. These alternatives come under the rubric of consumer-driven health plans, or CDHPs. CDHPs put more of the decision-making control in the hands of employees. The main idea behind a CDHP is that giving employees more responsibility for their healthcare costs will cause them to pay more attention to their health and healthcare-related treatments and plans. These plans are popular with employers. In the past several years, more employers have turned to high-deductible health plans, HDHPs, as a way to manage the costs of employee healthcare plans. HDHPs are also referred to as catastrophic health plans because they don't pay for the first few $1,000s of a person's medical costs each year. Thus, they pay only when the employee has a major medical problem. Because of their high deductibles, these plans are less costly for employers, and employees' monthly premiums are lower too. Employees in an HDHP can also participate in health savings accounts. Health savings accounts, known as HSAs, were created as part of the Medicare Prescription Drug Improvement and Modernization Act of 2003. HSAs are an example of an account-based health plan, an ABHP, a consumer-driven plan that pairs a group health plan with a tax-advantaged medical spending account. HSAs provide a way for employees to pay for their immediate healthcare expenses not covered by a high-deductible health plan, an HDHP, and save money on a tax-free basis. The basic idea behind an HDHP is that you can save money on the cost of the high-deductible health plan. Compared to having healthcare plans with lower deductibles, you can put aside the difference to cover the medical costs you incur. A health reimbursement account, known as an HRA, is another form of ABHP and is another mechanism for paying the healthcare costs of employees. There are several differences between HSAs and HRAs, even though the purpose of both is to reimburse employees for qualified medical expenses. As an employer, an employee, or an employee's family member can put money into an HSA. In contrast, only the employer sets aside money in an HRA. Employers can deduct the cost of HRAs on their taxes, and in the same way, they can deduct the cost of health insurance they provide to their employees. When the employee leaves the company, whether that's for retirement or other reasons, funds left in the account are accessible to the employee. However, the accounts are not portable. They remain with the employer that provided them, and they cannot be used for retirement income. In an HSA, the funds belong to the employee, and they can be rolled over to the next plan year and withdrawn for retirement, subject to a penalty if the withdrawal occurs before age 65. Only with a few exceptions, employees who have an HRA cannot have an HSA. Instead of contracting with an insurer such as Blue Cross or Blue Shield or Sigma to design and deliver all or part of their benefits programs, companies can decide to self-fund their programs or self-insure. Many large employers and a growing number of medium and small employers make this decision each year. By self-funding, employers avoid having to pay premiums and taxes on those premiums, and they avoid some of the state requirements for benefits.